Thank you very much for the kind introduction. And indeed, this topic is, at least for me, by far more fascinating than keratoconus for cross-linking for ectasia, because in ectasia we know it works. We are just working on an evolution of the technique, fine-tuning here and there, but this is a radically new concept that could change the way we treat corneal infection in the future. These are my financial disclosures. And just as a short reminder, if you would like to visit us in Zurich for the 11th time, the International Cross-Linking Congress, and what I tell you today will also be found in our second edition of the cross-linking book coming out now, the textbook. When the G7, the biggest industrialized nations, met last year in Germany, they had three major topics. They spoke about global terrorism, global warming, and antimicrobial resistance. It's a major topic. Why? Because it is quite scary. If we talk about fourth generation fluoroquinolones, Vigamox, we think it's a fancy molecule. In fact, it's a molecule that is 37 years old. The quinolones, which is our last weapon against infection, were discovered in 1980. And ever since, medicine has not identified a new class of antibiotics. So the World Health Organization gave an imminent warning saying that by the year 2050, more people will die on a global level by infection than by diabetes and cancer together. People will die by normal pneumonia in 15 years because we will have no more antibiotics left. So any technique that does not use antibiotics to kill pathogens is highly welcome, and we believe that PACK cross-linking is such a technique. Now, if you look at infection, we see that we are speaking of a different level of threat to the eye when we compare it to keratoconus. We speak about an extrapolated 6 to 8 million new cases on a global level every year. The WHO speaks of a silent epidemic. And we have a diagnostic dilemma in many countries that are hot and humid with mixed infections. We have problems with costs. Even if most infections can easily be handled, it is not the antibiotic that is creating the cost, it is us. Tell your patient that you need to see him back 5 or 6 times. If the patient has enough money to afford us once or twice, we will run into a global health problem. And this is a problem every ophthalmologist is facing, to cornea specialists. Now, PACK cross-linking started in 2004 in Zurich. We had just created the first cross-linking device many of you might still use, first or second generation, when we learned from a different technique that was developed by the Swiss Federal Institute of Technology, the ETH Zurich, and it's called solar disinfection. And what solar disinfection is, if you have bad drinking water, you put it into a PET bottle, add riboflavin, and expose it to the sun. And after 8 hours, no more bacteria live in this bottle, no more fungi live in this bottle, herpes simplex virus is killed, acanthamoeba cysts are killed, everything dies in this bottle. So we realized then that, in fact, we deliver energy and we use riboflavin as a chromophore, just like SODIS. So we started looking into the effect of cross-linking on infection, and what we have learned over the years, our group and others, is that in every cross-linking procedure, also in keratoconus, you do not only do stiffening, you change the corneal fibers, the collagen fibers are organized, and if there are pathogens present, you stop their replication by riboflavin to the DNA or the RNA of the pathogen, and you provide huge loads of oxidative stress. So these 4 principles happen in every single cross-linking. For keratoconus, we only use number 1, but and part of number 2. But for corneal infection, number 2, 3, and 4 are very important. Pilot study 2006 and 7 in Zurich, Switzerland. We treated 5 eyes with therapy-resistant corneal infection. These were eyes that were pre-treated for 1 month without success, and then received a single at the time Dresden protocol, just like in keratoconus, and then standard antibiotic care, and all 5 eyes healed. 3 years later, Jess Mortensen did a phase 2 study, and he only used the Dresden protocol, so no antibiotics. 16 eyes treated, and 14 eyes only needed vitamin A ointment after the one-time cross-linking treatment. And this, of course, is very impressive to see. And this is where we all realized this could be something that may change the way we treat infection in the future. If we want to make this work on a global level, we need to simplify the technique, accelerate the technique, we cannot do it for half an hour, to provide access for all. And access for all would also mean do not work in an environment that is costly, work in the most simple environment we all share. The eye doctor in Bangladesh has maybe no access to an operating theater, but he has a slit lamp. So that's the smallest common denominator we all share, a slit lamp. And in the case of infection, I still remember when we started keratoconus treatment, up to 2007, we did all treatments outside the OR. It was in 2007 at the 3rd Cross-Linking Congress that we performed live surgery in the room next door, and then a colleague from the US said, what about liability? What if the person gets an infection? And then in a reflex, we all moved to the operating theater. But why do now that I know that I disinfect the surface, we started doing keratoconus treatments outside the operating theater. And in the case of an infection, I don't want the infection to walk in the same OR I perform intraocular surgery in. And why do I take a septic patient into an aseptic operating theater to perform an antiseptic treatment? So we have to really rethink what we are doing, have a dedicated slit lamp to do this. And then in order to simplify and accelerate, several studies were performed to understand, does it make more sense to treat early ulcers or advanced? And with the current technical settings, it makes more sense to treat as early as possible. So you have the biggest chance of killing the pathogen before it goes too deep. So please remember, the technique is not yet validated. We cannot stop anybody from doing it as compassionate use, as a second indication, but try not to use it where it cannot really work, in very far advanced, almost perforating ulcers. Try to use it in early ulcers. Otherwise, we will see a lot of complications that are totally unnecessary. The next step was to accelerate the treatment, and we managed to accelerate down to 150 seconds while maintaining the same efficacy in killing. So 98% of killing of MRSA, of Pseudomonas, of Staph epidermidis in 150 or 180 seconds. And this was the prerequisite to move to the slit lamp. We have clinical validation. We have used this accelerated PACK cross-linking. I cannot show you the picture because for copyright purposes, we are just about to submit it, and this presentation will be web streamed. But I would love to show you these pictures where 3 minutes, 180 seconds of treatment in a medium-sized ulcer just kills all the MRSA infections and bacterial infections within short time. We are running a prospective phase 3 randomized multicenter trial involving a huge number of sites and countries to provide the final evidence that PACK cross-linking is not worse than antimicrobial treatment, and you only need one go. And all this to bring the technology to the slit lamp. And the idea is to have a sterile interface in between the lamp and the patient's eye, and then provide a technology that allows you to do anything from Dresden protocol to highly accelerated, being highly mobile. It will fit on size Topcon Hug-Stride slit lamps. This is the prototype. And besides the sterile tip, we believe that you can also treat keratoconus. I think a working epi-off keratoconus treatment will be somewhere between 5 and 10 minutes. Ulcer is highly accelerated down to 180 seconds. The device will have beam optimization. And this is very important if we give it into the hands of also general ophthalmologists for small ulcers, is real-time measurement of fluorescence of the riboflavin. If the device does not measure enough fluorescence, it will refuse the treatment. So in conclusion, PACK cross-linking can be accelerated to 3 minutes. Efficacy rates in bacteria are between 95 and 99%. In fungi, in Aspergillus candida, around 60 to 70%, so it works in mixed infection. CXL at the slit lamp should give access for everybody, and the device will be available in mid-2017. Thank you very much.
Thank you very much.